Next, we're going to have Dr. Herrel come up to speak. She's the medical director of our operating rooms. I'm sure she hears a million complaints through her emails. She's associate professor of urology, and she will be talking about our urology workforce.
Awesome. Well, thank you for the opportunity to be here today. It's exciting to talk about this topic, largely because many of you have been involved in some of this work and have been a part of advocacy efforts to move things forward. So as Dr. Go mentioned, I'm a urologic oncologist here. So I take pride in training trainees, in taking great care of patients and in being in the operating room. I do research on health disparities in the intersection of health policy and vulnerable populations with cancer. And then, as Dr. Go also mentioned, I am the medical director of the operating rooms, and I like to joke that we put out both figurative and literal fires on occasion, so it keeps us busy. But all of these different roles really help me understand and kind of have a different vantage point on factors that are impacting the workforce of urologists across the nation. And so I get to kind of see how this impacts different ways of how we deliver care and some of the stresses that we all face in doing so, and different ways to look at the problem. So I think this is one of my favorite pictures on the left. Stu Wolf is here. He just stepped out. But so Jim Dupree, Stu Wolf, and I went to the AUA Advocacy Summit in 2016. And at that time, I really didn't understand the gravity of the issue that was facing the urologic workforce. But we went to the Hill, and I learned a lot about it, and I learned how to lobby and advocate for our profession. And this was a really incredible experience, and it shaped a lot of kind of my future training and work moving forward. The AUA has recognized this as a policy issue and what a great issue it is facing our profession, and is fiercely advocating for different ways for us to solve this problem. We have gathered a lot of information about this through the annual AUA census. So this is my plug. I think you have like one more week to fill out the census. So if you haven't filled out the census, please do. We use that data to help understand exactly what's going on with the urologic community. The AAMC, the AUA, the AMA have all predicted a very significant physician workforce shortage that is coming over the next decade, and really, frankly, it's here, and I think we're seeing the impact of that in our practices. So it's a huge, huge shortage, tens to hundreds of thousands of physicians that we're missing out on. That shortage is particularly severe among surgical specialties, and we're facing that now, and we all kind of see that in our daily practice. Some of the factors that impact the supply of physician is the really long pipeline to replace one physician who leaves. So it's a long, long course, and there's many places along that course where people can kind of fall off the pipeline. As many of you know, there are GME slots, residency slots that are funded by Medicare. This was capped in 1997, and basically we had no growth in funding for residency positions since 1997 until 2021, where we got 1,000 more spots. So there has been some movement in this area, but it's just not enough. And then a lot of people who are coming out of residency have a preference for metropolitan practice locations. And so that leads us not only to having a shortage, but then also having a lack of physicians in rural communities. And we kind of have a mismatch between having lots of physicians in areas and not necessarily where the patients are. Burnout has particularly impacted the urologic workforce. It has been an ongoing problem for a long time, and it was exacerbated by the pandemic. And then interestingly, our aging workforce, particularly for urologists, about 40% of the current workforce will reach retirement age in the next decade. So more to come on that. So this workforce shortage is also coming at a time where we have increased demand, and this is driven by population growth and aging. So 42.4% of the population will population growth in this over 65 crowd, and that turns out to be about 11,500 people every single day. So it's a tremendous number of patients. That aging population has increased demand for specialties that treat older adults. And so this includes folks who are needing joint replacement. Orthopedics is facing this problem and trying to figure out how are we going to do joint replacements on all of these aging individuals. And then we also see that a lot because the Medicare age population utilizes urologic services at 3 times the rate of the general population. And we all know that from the patients that we see. One kind of interesting caveat to think about is that the current barriers in accessing care effectively limit demand. And if we were able to meet all of the demand of, there may be a system in place where alleviating barriers actually led to an even further increased demand. So we don't really know the true demand because we have such an access problem. So I want to shout out to these three individuals who have been just absolutely critical in doing this work. Kathy Nam, who graduated from residency last year and is doing her infertility fellowship at Northwestern this year, and we're all super thrilled to have her come back next year. Kate Kraft, who helped pioneer this work as well, and then Stephanie Dano Newton, who did all of the analytic work for these projects. So Kathy really brought this problem to us and said, hey, there is a physician workforce issue. All of the data that we have is about 30 years old. And so she really wanted to better understand it, understand what women's role in this is, understand how work-life balance impacts this. And so Kathy did all of this work, and I take zero credit for it without giving it to her. So what we did with this work was try to understand what the physician workforce is going to look like. And so we built 2 stock and flow models, and it accounted for incoming urologists and retiring urologists, because these are 2 factors that are coming in and out of the workforce. So we got our numbers mostly from the AUA census from 2019, and then we used the ACGME resident data resource book to estimate how much growth in resident capacity we have on a yearly basis. And so residency growth was one of the key items that we identified as a way to continue to grow the pipeline in urology. And so over a 5-year period that we looked at, that growth rate was 13.8% in resident composition across the US for urology. And so we applied this to some of our models moving forward. So we had our growth model, which accounted for a 13.8% growth in residency positions every 5 years, and then a stagnant model where there was no growth, and tried to understand exactly what that would look like. We then layered this on to population estimates using US Census data, and this is work that we published in JAMA Network Open. And so here you can see this is for the total US population from 2020 to 2060. The top kind of dark blue line is all urologists. And you can see that even with growth, we are going to be facing a shortage of urologists, and we're going to have fewer urologists per 100,000 people than we currently have today. And that gets worst case at 2030. If we don't have any growth in residency positions, we will basically never recover from where we are today. And so we will have even worse shortage than we currently have. If we specifically look at the population that is 65 and older, so that Medicare population, you can see again in this growth model on the left, we have kind of a nadir at 2035, between 2030 and 2035. And again, if we do not have any growth in residency positions and don't somehow increase our workforce, we are going to continue to have a decline in the number of urologists for patients over 65. So the take homes from this were that without the growth of resident complement for our current number of urologists, our current number of urologists will decline and will not recover to current levels by 2060. Due to the U.S. population growth, particularly those over 65, we will have a declining number of urologists unless we have resident complement growth. Even if we do grow our residents, we're going to see an exacerbation of shortage, that dip in the graph that we see around 2030 and in 2035. So our kind of message is hopefully we can expand residency positions to buffer this impact to get more urologists out into the workforce. Not having enough urologists is a big problem. We all see it and we feel it. It results in limited access to urological care. So this bottom right graph is a screenshot from my TV like one weekend ago where NBC was reporting extremely high doctor wait times, and patients just aren't able to get the care that they need. And it's very problematic. People are sitting with disease that becomes metastatic. It becomes so severe they need to either come to the ER or it can impact their overall lifespan. The increased travel required to get care because urologists aren't in patients' communities is becoming longer and longer and making it more challenging for patients to get where they need to be. This disproportionately impacts rural and underserved populations. Only 38% of counties have a practicing urologist. So we know this, we see this, but it's just very challenging, and the numbers are pretty stark. So I don't want it to all be doom and gloom. I want to think about what can we do to improve our workforce. So I like to think about this in non-modifiable factors and then things that we can do. So the increased demand from an aging population and the increased rate of retirees exiting the workforce, those are just kind of facts of life. Our urology workforce is older, and so just as our population is aging, our population of urologists is aging as well. Some of the things that we can modify is to increase the complement of residents to help build out the future urology workforce, reduce burnout, hopefully make it easier for those folks who are currently practicing in urology to make sure that they stay within the workforce and that they're able to be efficient and happy in doing their work. And then also enabling current workforce to focus more on direct patient care, so reducing and offloading administrative burdens, reducing regulatory burdens, things that are not contributing to direct patient care. And then enhanced support for all and from all team members. And so there's a lot of work that can be done by some of our additional staff. We're a huge team of urologists, and we can all deliver really high quality care. And I think the more that we can build out our teams that are capable of delivering urological care, then we'll be able to reach some of the patients that we need to reach. There are a lot of policy solutions for this. There are tons of efforts going on in Washington, and I think, we really need to be advocates for this work. I'm going to go through kind of some individual aspects of policy solutions that we talked about at the AUA Advocacy Summit. These are some of the asks that we took forward to our congressional leaders on the Hill. So I do think there's reason for optimism. We've been a vocal group. The AMA is a vocal group, and I think we've made some progress. Prior authorizations are one example. So there's 182 million prior authorization transactions annually. It's like a tremendous amount of work, and you have to understand or ask the question of where is this adding value? Most of these were handled by hand, and it's estimated to impact practices about 14.6 hours a week. So that's a portion of a full-time staff that you're spending doing prior authorizations. They're an obstacle to necessary care. They're difficult to navigate. Every payer has different requirements, and it results in long waits and often patients abandoning care. And so the CMS interoperability and prior authorization final rule was set forth, and essentially it's congressional leaders who are working with government payers who are really trying to make this easier for physicians. So decisions need to be made quickly, and there is an effort to make sure that this is all done electronically so that it can be expedited, and so that people understand if there is a denial, exactly what that reason is. Other asks that we had in specific terms of supporting the urologic workforce, there's a Resident Physician Shortage Reduction Act. And so this is specifically to ask about funding those additional GME slots and kind of focusing where those slots are dedicated to make sure that they're going to places that need it, such as rural counties, and then those who are training over the GME cap already, so that they're already paying more to train physicians at their institutions. There's also programs that are put forth to help request J-1 visa waivers for folks who are practicing in federally designated shortage and underserved areas. And that has been ongoing. Many of these we've asked for year after year, and they usually do get bipartisan support, so we've been optimistic with that. There's also the Spark Act, which gives loan forgiveness for rural physicians. Telehealth is a very large focus of a lot of what people do. I know Dr. Elimuto has spent a lot of time working on this and advocated for this. He was on the Hill asking for increased expanded coverage of telehealth resources. So 70% of urologists use telehealth. It helps to reduce the burden on patients who have to travel, and it's convenient for many more, both physicians and for patients. A lot of the pandemic provisions that were put in place that allowed us to all rapidly expand adoption of telehealth have been set to expire, and a lot of these are just really silly rules that don't have to exist, such as having a patient have to go to a physician office to do a telehealth visit. So the Connect for Health Act was one of the bills that we advocated for in terms of maintaining these current provisions so we can actually deliver telehealth and continue with reimbursement. The final thing that we advocated for was Medicare reimbursement. So you all probably have seen this come out through the AUA. They've done a good job of talking about this, but specialty physicians face a 2.8 Medicare reimbursement cut basically every year. It's happening again, and we're continuing to advocate that this not happen. As you know, prices are all rising, yet the physician reimbursement there, that bottom purple line, you can say it's not just stable, but it's actually going down. And so we're really trying to make sure that we increase the physician fee schedule so that practices can stay open and you can continue to provide care, because without this reimbursement, we simply can't provide care. And there's also efforts to reform some of the quality payment programs that came out through MIPS and alternative payment models to try to reduce some of the administrative burdens with those programs. I thought this was a great quote, and it was a really important way to remind ourselves that I don't think we can all just sit here and expect change to come from Washington and expect them to do the right thing. They don't know what we need. They don't know why we're advocating for what we're advocating for. So if we want change, we have to bring it to Washington. And so this is my plug for all of you to think about going to Washington through the AUA Advocacy Summit. They make it silly easy. You just show up. You don't have to know anything about lobbying. You don't have to know anything about the topics. They'll tell you everything you need to know. And our goal is to just go there and try to help lawmakers understand exactly what we're facing, what our patients face. I've had a really fun time doing this, and it's something that is not part of my daily work, but I think it's really important. I think it allows us to do what we do. I still think we have the best job in the world, and I just want to keep doing what I do, and hopefully we can kind of keep a sustainable workforce in the future so that we can all keep doing what we want to do.
Do you have any questions?
Yeah.
So, in the workforce models that you're referring to, has anyone done work? Because what you're assuming is urologists will continue to do practice the way urologists practice, but we know that's changing. So what has been done in terms of other models and looking at the workforce and how we change how we practice, like more PAs into the mix? Does that mitigate the problem that's coming?
Yeah, there's been a couple of efforts that the AUA has looked at. So one is training advanced practice providers to be able to come and do some of the work. Some of it is how much can they do independently without a urologist? Can they see patients, work them up, do scopes, do biopsies, things like that to kind of help get some of that at least available to people who need it to help offload what has to be done specifically by a physician. The other effort that is underway is trying to train more primary care. So can folks who are already in some of the rural communities, can we help expand their knowledge and understanding of urologic conditions so that they can do some of these things? I think it's really great and it's a great idea. I do think that that's a lot of burden to put on a primary care physician. Like they can't be basically do all of primary care and all of specialty care because everyone is trying to push some of the stuff off into some primary care practices. So I think we need to be creative. I think between telehealth, expanding the workforce, making larger teams who can help deliver that care is probably the way to go.
Yeah, thank you. Yeah, thank you, Lindsey. Is there any kind of effort going on in the artificial intelligence to kind of help with some of the care that's going on? Because there is a pretty big gap right now between primary care and specialty care in terms of knowledge and practice, and it's actually, I think we all know it's growing, and it's got to be, something in between that maybe doesn't require a human being to do.
Yeah. I don't know of anything specifically going on, but I do think that that's a great idea. And I don't know if Juan is going to make a comment about this. Okay. But I do think it's a great idea. I know one of the things that we struggle with on the cancer side is survivorship. And so do we keep these folks coming to the University of Michigan for cancer surveillance for 5-10 years? Or can we try to somehow get it back? And if there are standardized protocols for these patients, AI might be a great way that we could kind of keep patients on a schedule that doesn't have to have such a kind of high touch burden.
Heck yeah, I love that. Good morning, everyone. Yeah, I was just going to answer that comment specifically, at least from the AUA side. The telehealth task force has been around since I think about 2016, and there's internal movement and the action to try to expand it to include all digital health, including AI, because right now it's a total Wild West. And even at the state government levels, there's very little regulation or planning as to how it's going to be used effectively. So I think that area is going to be probably one of the biggest next frontiers.